Hello, my name is Minna-Liisa Luoma, and I'm going to tell you about elderly care at home with age, technologies, and experience to adopt technology in Finland. So, why do we need age technology and national coordination also in home services for older people? First of all, Finnish demographic change is very rapid, and Finland is aging very, very rapidly. And because of that, the cost of services for the elderly are increasing. And also, we have a real shortage of professionals, and that is getting even worse. For example, services for elderly people alone will require more than 30,000 new carers by 2030. And also, digitalization is lagging behind in Finland. Devices and services are deployed locally and often on a product basis. Co-creation of manufacturers and users is sporadic, and well-being counties are looking for solutions to the same problems, but results often remain local. And information about effective solutions spreads out at random, if they want to spread it out, and formal evaluation, comparison, description, and dissemination operating models is lacking. And that's why we had in Finland the GATI technology supporting smart care and aging at home, a national program. Its objectives was co-creating and piloting deploying technologies by renewing service operation models for living at home. And also what I'm going to tell this more today is evaluating impacts on welfare, home care, personnel and costs. And just the basic numbers that we have 6 regional projects and 13,500 home care clients and 4,500 professionals. So we have a very good data on that. And then we had from the program, outcomes were 62 nurse service models and holistic impact evaluations, GATI model and reference business architecture, and national coordination model for continuity and collaboration between various parties. And what we created is a national tool for well-being service counties, the GATI model. It is tasks for the technology deployment and technology use in customer path. And technology use starts also in living at home and advisory services. And it goes also in service needs assessment, operating services and service plan, administration decisions, provision of services, and assessing services need, and termination of services. And this in technology coordination needs service management, total process management, evaluation of the use of the technologies, architecture and connections to the platforms, ensuring safety and utilizing operating models, device management and access support, and ensuring competence for skilled personnel and communication between parties. And what were the technologies we piloted in GATI projects? There were so many, and we grouped them in this kind of group. Remote health measurements, for example, measurements of vital signs or weight at home that are automatically transferred to care information systems. Monitoring technology like sleep, activity and nutrition monitoring, safety increasing solutions, wearable safety solution with GPS localization and medicine dispensing report, medicine reminder, and monitoring falling. Solutions for supporting social activity like virtual peer groups and coffee groups, solutions supporting rehabilitation, games activating performance, physical activation solutions, and exercise equipment. Technologies installed in the apartment like home condition measurements, temperature, humidity, light safety monitoring system at home. And technologies for care professionals, for example, electronic home care optimizing system, virtual home care or consultation visits, virtual reality-based training, and EO transfer and integration platforms. Data from devices, applications, and services at home are collected in the platform to be further analyzed by care professional or artificial intelligence. So there were so many technologies we had. And then we had some kind of new technological devices and impact. What were the impacts of them? Work for professionals, new technology assisted operating models, new skills and possibilities, care information about elder's well-being, realization of the treatment, motivation gained by concrete aid, and enabling leave out some concrete procedures as unnecessary. And well-being of people, well-being of professionals, we found that it does not decrease even use many technologies. Older people find remote care meaningful, can talk about daily issues, and it also for them supports coping at home and sense of independence and security. For near response, the technology means reduced worry and enable care remotely and being easily contact with an elderly person. Cost for home care decrease of physical visits, and it saves kilometers and money and time. And then we, even though we had so many different technologies and so many different areas, we conducted a study how to adapt technology to meet the needs of home care professionals, older people, and informational caregivers in home health care. So this can be found from the BMC Health Service research paper. And the setting was like that. First, we had to have a lot of background information about piloted technologies, and we collected quantitative and qualitative data. And then we had to know what were the requirements for technology use. We also collected qualitative data, semi-structural focus groups, and then we wanted to know what were the effects of technology. Also, we collected qualitative and quantitative data and repeated team survey by web poll. And data analysis were like first of piloted technologies, requirements for use, and effects of the technologies. And the results. First of all, requirements for technology use. It's first of thing is perceived usefulness and requirement for usefulness. Professionals and people, caregivers, their opinion were very similar, like family, commitment, understanding the benefits and skills. And then sometimes there were also no requirements. And what impacts for perceived usefulness was rehabilitation and appropriate care and risk allocation, data collection and monitoring, safety fellowship, and so. And then it was one of the things for requirement to use technology was perceived ease of use. And if technology was easygoing, it was successful. Problems at the beginning, they were very common, need maintenance, problems with the techniques. And these has to be solved those problems. And also attitude towards technology is a requirement, because if attitude is favorable, trusting, it's better than suspicious and resistant. Intention, and then intention to use technology, because how it continue, if it's uncertainly, and not to continue, and it depends, of course, because this was a project. People thought that it might stop when this project stops. Sorry. Requirements for technology use. From professional older people caregiver perspective, professionals considered family commitment and understanding of technology benefits to be requirements for technology use. And if technology use has been positive, easygoing, successful, and it was thought that use would continue in the future. The received benefits are usefulness and keeping older people up the world are important in technology use. And also the attitudes of home care professionals can potentially affect how older adults are viewed in relation to technology. It might either promote or hinder the adoption of the technology. Therefore, it's so important to bring out gaps in technology use to meet the needs of users and to educate challenges work processes. Familiarity and commitment were described as being important from professional older people and caregiver perspectives. And experiences of work and working process changed when technology is adopted in home care. First of all, it changed in skills like technical insights, work control. And it changes also information provision about well-being, realization of care, new care possibilities. And it changes in procedures, information provision, new procedures to cope at home, and possibilities to do existing procedures differently, like visits and caring times and involvement. Existing procedures can be left as being unnecessary. Very concrete procedures, cognitive orientation, and ensure care patients, and changes in motivation. And there were also, in every single thing, that there were also people who say there is no new changes. It doesn't say skills, it doesn't say information provision, it doesn't say procedures. So people thought that, but major of the people thought that it has some impact how to work processes. And what were the very important? There were new skills and feelings of security. Technology use was thought to provide new skills, like such a technical know-how increased. Professionals learned how to deal with technology equipment in practice. For example, set up alarms and use variety of systems. Older people learned new ways to use technology and receive help at home. Technology use provide information in new way older people's well-being. It enabled to modify visits and caring times, focusing on participants' needs. For example, visits and care were able to be more modified based on needs. Professionals received information easily, and they were able to reconsider the urgency of the care they needed. Older people, on the other hand, they didn't not need to wait for the care, and caregivers no longer needed to be committed physically to older people care so much. Technology provided also real-time information about realization of care. For example, professionals were able to track medication intake and focus on gap in care, for example. Older people were better aware about daily practices in care, and caregivers received information about that, meaning that older people were cared for timely way. And then some of the advantages of technology. In technology use, it enables some concrete procedures to be left out as unnecessary, which is also very important in saving time and money. But for example, professionals did not need to travel to the older people home so much anymore to ensure the realization of care practices like medical intake and offer physical company to other people. Older people did not need cognitively orientated. For example, remember the treatment and localization was possible even the older people could not memorize the medication or localization. And there, it also provided positive experiences. Professionals' work became easier and they were able to allocate their resources more effectively. Old people were motivated when they saw changes in their independence and safety, and they saved money at the same time. Caregivers were motivated when older people were able to be independent, safe, and they saved their own efforts and money. And then there were quite a few advances of technology used for caregivers. Technology has a significant role as a source of support as technology use facilitators, especially it improves their psychological well-being by easing their caregiver burden and relieving some of their responsibilities. Technology is a means of change clinical practice and develop work. Caregivers could find new necessary procedures to engage in older people's lives. Technology ensures older people's well-being, but no longer need so much tracking, making checkup visits, and relying what they said, and they knew what has happened also afterwards. The importance of concrete aid to change at the same time as well-being of older people was being ensured. Technology was a means of being aware of older people's safety and their ability to cope at home in distance-based care. It means to getting benefits such as saving time, costs, and better allocation of resources, especially among those who are geographically dispersed and spend a lot of time in the field, because Finland is a very large country and with long distances. It can also mean continuous on-site training and learning, variation and communication throughout the organization. Its use provides opportunities, for example, for such persons who are unable to work at the older people's home due to physical restrictions, so people can work longer and keep their jobs, even though they have some physical restrictions. And what we learned there, also, this is maybe one of the takeaway messages. The success of technology, including the level of adaptation by users, is independent on the end user's interaction with technology, how they feel, how they adapt, what are their attitudes. Also, it needs some skills. If there is no skills, they have to be taught. And it is dependent also on the belief that use of technology will benefit their health and life. And it also needs what is needed is available funding and also the policy decisions. Are we ready to go for the technology, or are we staying in old way of doing things? So this is my speech, and I'd like to thank you very much for inviting me this session, and please be in contact if you have any further questions and or requirements for me. Thank you very much.
Thank you, Minna-Liisa, for sharing the experience in integrating technology into elderly care. Hello, Minna-Liisa.
Hello.
Hello, thank you for your time. So let's have a look at the questions from our floor. From your point of view, what are the most important factors that hinder the professionals, older people, and caregivers to adopt the technology use, and how to encourage them to use technology in home care?
Well, I think the most important factor to hinder is first of all attitudes, and then of course if there is no skills to do that, and also the politics, because if it's not really adopted like as a chance to do it, and also if we only have projects that are to use technology, and then if the project ends, then the technology use finished. So it has to be some kind of national willingness to adopt technology, and because it in any case comes in somehow.
Thank you. Yeah, it very give us a very good point that a national or a policy level, that the friendliness of it can actually help a lot in promoting home care. And another question from our audience: can you share how Finland promotes the use of technology for elderly care? Any subsidy or fundings to organizations or elderly?
Yes, actually in Finland there is a lot of development money ongoing to the well-being counties to adopt technology, and also we have created a national coordination team where all the most important players are involved, and that's what we are doing exactly now. And the Finnish government has put a lot of money for health and care technology in this government period.
Amazing. The government role is inevitable, and how that actually paved the way for lots of easier policy, and how it adopts into our, no matter in academics or in social service or other areas. Another question from our audience: many Asian cities like Hong Kong are also facing serious aging problems. So is it possible to carry out similar program like KETI program in these cities as well, and what extra attention needs to be paid if we do so?
Oh yeah, nice question. First of all, I think you could take our enterprise architect model, because it's very good, because we have been thinking every single step how to adopt technology. So, and then you have to adapt it in your own environment, and of course, what is the extra attention? I would think that the skills and attitudes, and also the process, you have to understand your own processes and how to adapt technology there, and where, if it's, and exactly think where it is needed, mostly needed, and what are the most you both benefit in many ways in your clients and your nurses or carers and other professionals, and of course the costs, and not only the short-term costs, because usually when you start using technology you have higher cost at the beginning, and then you understand that if you adapt it well and you make all use of it, then the cost will reduce in a long way.
Thank you. Another question from the floor. It is understanding that a small group of people in research think technology does not have much impact on them. Did KT program further respond to this group and any measures to change the stigma around technology?
I think yes, because now, because it was, the KT program was based on well-being counties, on their personnel and their skills. And also we had very big client involvement. As I told that we had so many clients and so many hands-on workers there to do. And then what it has also created that in all legislation now, we have a regulated amount of staff ratio in long-term care. Now the government is going to change the legislation that we can have a little bit less staff if we use certain technology in long term, because we know that, for example, safe technology, if you have very good safe systems where then you don't need so much personnel at night to just take care of the people that everything is okay if they like safe floors or something things that detects clients if they wake up in the middle of night or fall out from the bed. So that kind of things, and also medical dispensers, which can be used very safely, and it lessens personal costs.
Thank you. It is great to know various kinds of technologies piloted in KT. The question is, may I know if there are any selection criteria on tech solutions to be able to participate in the project?
Selection. Yeah, well, it is of course there was a selection criteria. It was something that they would have in any case to try or adopt, and also that technology that they have already piloted in some other counties. We took that kind of technologies, and the point was also that even though the most of the technologies, they were like medical dispensers or things like that, which were not very new. But we wanted to have in this project that the research, how the technology benefit, because the problem is also that, for example, in Finland, the well-being counties, they just take some technology and then nobody knows what was really the benefit on the technology, and then it doesn't go to other well-being counties when we don't know what were the benefits. So that's why in this kind of project we needed to have we had a lot of technology, and we tried to understand because there are various of technologies in any case, to understand what is the benefit try to take them and use, and what were the impacts on quality of life and personnel, and also the costs.
Thank you very much, Minna-Liisa. Thank you for your time, and we hope to see you in person in the very near future. Thank you.
Oh, thank you.
Thank you.
Goodbye.
Hi, good afternoon, everyone. My name's Arthur, and I'm from Humanetix. I'm very excited to be here today to talk about our next generation aged care ecosystem application that we call ACE, and the digital nervous system for aged care. So thank you for everyone's time. Just to really quickly, some background about Humanetix. We're an aged care technology company founded in Australia. Our mission really is very simple: to simplify care through technology. We want to give clinicians and nurses and carers the opportunity to focus on patients only and not have to worry about administrative work and be able to just focus on delivering care. We've won some awards that we're very excited about. We're the Patient Safety Award finalists. We're the current winner of the Innovation Australia Software Innovation Award, and we've won some Future of Aging awards as well in Australia. And we're very excited about the work that we're doing. As I mentioned, we have an aged care solution that I'll be talking about today. The solution was designed in partnership with the Australian Department of Health over here, which is very exciting. We've been in the market for about 3 years now. We've delivered more than 10 million clinical activities in the last year to more than 5,000 residents and clinicians in Australia. We have clinically proven to provide clinicians with an extra 1.6 hours per 10-hour shift in terms of the time that they get back from being able to deliver care as opposed to doing administrative tasks. And we have a great net promoter score where clinicians and nurses that use our system actually really love using our system, which really sets us apart from other solutions out in the market today. So what do we actually do? So at its core, we have a technology platform that's built on 3 core principles. Number one is that we're extremely client-centric. What we mean by that is that we're extremely focused on the resident or the client that comes into your aged care facility. And everything we do is centered around what's best for them. We're extremely contextually aware as well, meaning that we know about all the latest things that's happened to your client. So all the recommendations, all the tasks that we do are based on the latest information that's come through. For example, if someone's had a fall yesterday, we know exactly what the recommendation should be because they've had that fall, or if they've had a BMI change or anything like that, we're extremely contextually aware of what's happening. And we're future-proof. You know, we know that there's a lot of change happening in the sector today. We know that there's a lot of opportunity out there. We know there's a lot of older people coming into different facilities, and that we know in the past systems have been installed and then you can't upgrade or change them. We're completely customizable through configuration, which means that we're able to always continuously change the way we do things without being locked in to the way things are being done today. And what that does is it provides a digital nervous system for your aged care facility. What we have at the very core of everything is our AI clinical decision support engine. We have a global patent around how we do that, which really takes into account the requirements of a client of yours in your organization. They come on board into your facility. We take an assessment of their existing health situation, their health background, where they hope to, what their health outcome and goals are. That goes into our decision support engine. We then create an automatic care plan, and these care plans are then turned into dynamic smart workflows that then give carers and clinicians the ability to look at their application and know what should be done to the person, what has been done to the person, and what still needs to be done for your clients around that. It's got built-in clinical pathways, and also it can integrate with all the different sensors and devices, such as your fall detection sensors, blood pressure monitors, everything else that you have in there to create a single workflow for your clients. And we're very proud of that. So what that means is for your clients that then come into your facility, they have a really smooth journey. So if they come on board, it starts with awareness. It starts with telling them, hey, with a bit of a CRM that shows them how great your facility is, what they can do, why they should come on board your facility. Once they're into your facility, we then have a really efficient onboarding and support mechanism, where, as I mentioned before, we look at 160 different data points of this client that's come on board, what their health requirements are, what their blood pressure is, everything like that. And that then goes in and creates an automatic plan that is automatically updated based on the latest activities that's been done to your client to ensure that they have the best care possible. The application also works across all of your people that deliver care around it, including doctors, family members, traditional Chinese medicine providers. Everybody else gets to see the same information. They all get to use the application and provide the same kind of care to your client. And as they transition into different kinds of needs, moving into complex care, they need to move into hospital, if they need to go into palliative care, all that is done automatically within the system, but everything is centered around the resident and your clients around that. Every bit of information is stored against your resident, and every bit of activity that is done is around your resident as well. So really, it's an incredibly smart and intuitive system that's extremely easy to use. But as I mentioned, our job is really focused around helping the healthcare team, your clinicians and your nurses, to be able to do their life easier. We know that there's so many things in their head today that they have to keep in their head, or even if they use the digital system already, quite often they have to run back to the system to be able to document stuff, or just, be able to document things, as opposed to have a really smart clinical decision support facility to help people. So really what we provide is we provide streamlined handover and dashboards, complete resident health information and life story. Dynamic care plan really means that when you pick up the application and look at your clients and your patients that are assigned to you, you see everything that has been done to them already, everything that should have been done to them but was missed, and everything that still needs to be done to them, all in one situation. And as I mentioned, it is completely contextual aware. So if you were, for example, to miss turning someone over to prevent a pressure injury, it will automatically update and remind you to do it again in the future. Or if someone's had a fall, you no longer need to look at them for pressure injuries because they're in a different kind of care path. That will automatically change as well. And it's all baked in with extremely strong standards and all of the clinical operation requirements that you may need to bring into the thing as well. So we're very excited about the fact that it's able to give your healthcare team an extremely streamlined view of the clients and patients that they're looking after as well. But really, it's great to have a great piece of technology, but for us, we've really focused on getting proven results around this. We worked with the University of Canberra over here in Australia and did a 2-year time and motion study where they came in and observed residential aged care facilities that used our application to see how much of an impact we're actually having. And the results were frankly staggering and really, really surprised us as well. We saw 20% time savings across the board for everyone delivering care, which equates to 1.6 hours extra of care time given back to your nurses and carers around that. We saw 58% increase in goal settings. We saw a massive increase in completed evaluations and a much better client care delivery, which really means that your nurses and your workforce can actually do more with less, while at the same time giving patients better care. And it's all independently proven, with the University of Canberra study around that. And we're able to do this really by combining our best of breed residential aged care configuration that we worked with the University of Canberra on, but then also working really closely with each individual provider to then customize and configure their specific requirements. We know that a lot of different providers have different ways of doing things. Not everyone does a wound the same way. Not everyone does a pressure injury the same way. And we also know there's a lot of new workflows coming out. There's new guidance coming out all the time about how things should be done. And that's something that we're really focused on ensuring that you have in your hands as well. So we allow, from a very simple way, to personalize the configuration of how every single workflow is done, how every single clinical care pathway is done, and then it can then automatically be scheduled for the way you want it to be done as well. So we work really closely to deliver something that's extremely personalized to your carers and also to actually the service that you offer to your customers as well, because we know that you spend a lot of time customizing the service offerings that you deliver to your clients so that you can have a bit of a competitive advantage as well. And we work really closely with you around that. And we do this in a way where it's all done from an app basis. I know everyone, being an application, a mobile-based system should come naturally to everybody today, but unfortunately, that's probably not the case in a lot of clinical care systems out there today. So we're very proud to be a very strong mobile-first application, but we also work really closely with how your clinicians want to work. A lot of them like using desktops today, so we can still operate on a desktop, no problem. And if people like using tablets, that's not a problem as well. But what's really also really important is that all the data that we're gathering is incredibly important to be used in a reporting method as well. So we're not able to just kind of gather all this data. We're actually able to report back on it. You're able to look at incident management, complex care situations, all in kind of one location around it. And when you combine the ability to have an intelligent care algorithm like we have, powered by AI, the ability to then have all your clinicians and nurses document care in real time using your devices, and then the ability to report on all of that real time, it really does provide a digital nervous system that can seamlessly support reactive, proactive, and distributed scenarios of looking after care. Really what we mean is that you're able to be reactive. For example, when someone pushes their nurse call button, you can configure a whole bunch of really strong workflows to happen automatically in terms of ensuring that everything is done properly. If someone falls over, you can then, fall detection sensor has someone detect if someone's fall over, you can automatically schedule the incident review. You can automatically go and notify the family. And you can also automatically store that, all of that in your clinical documentation system, all in real time. You can also be proactive as well. We know there's a lot of incredibly smart sensors out there that can detect when someone might fall, or there's incredibly smart sensors around being able to see how your cardiac risk levels may be. The other thing we also do is we also calculate cardiac risk scores and other risk scores in real time. A lot of industry standard scores that can be taken and calculated in real time. And based on that, we're able to trigger preventative situations as well. So for example, if someone has a device that says you might fall soon, we might automatically trigger a workflow to do a fall risk assessment. When you do a fall risk assessment, you notify the family. You can do a lot of different smart things to do early proactive prevention as well. And then what's really interesting as well is we're able to do distributed information as well. We're able to share all this information with their GP, with their doctor, with their family member, with their nurses, so that everybody can be part of the solution around how to deliver care for your residents. And that's quite an exciting piece around it. And being able to be both reactive, proactive, and distributed, we really believe is the future kind of healthcare for in residential aged care situations. And most importantly, we know that the most important part of all of these new innovations is that it must fit in the workflow of the clinicians, which is why we've been so strong on being baked into the core workflow of your clinicians and being able to take in data from different sensors, different places, so that it's not just another application that they need to look at. It's not just another bit of noise, another notification. We all know what it's like to have too many notifications around us. So having it all fit into one workflow is the key is the key that allows us to deliver what we do today. So now on top of that, though, there's a lot of really exciting innovations that we're doing as well. We're actually launching a bunch of generative AI-powered handover and summary notes. We know that one of the biggest friction points in a residential aged care home is during the handover period. And with technology today, with the ability to be able to take everybody's data in real time, we can also generate automatic handover and summary notes. What this does is it allows people to come in and get an automatic summary of a client's condition, their cognitive health, and everything that's happened. It helps with family communication to be able to automatically do an end of shift summary to the family, and also monitoring all your nutrition and diet and anything else that's important to you as well around that. We're also really excited to say that we're now launched in 24 different languages as well. So our application can work in multiple different languages as we look to expand beyond kind of Australia and cater to different family cultures as well. The other thing that we're also really focused on, as I mentioned, that our job is to simplify care through technology by removing the mental load from clinicians and nurses. We've been really strong on ensuring that while our application is focused on the patient and resident and client outcome, but the user is your nurses and your clinicians. And we really want to make sure that they have a great time and enjoy using the system. Because if they love using the system, it allows them to actually use it more, which then creates even better outcomes for your clients and your patients, which is why we're launching some gamification capabilities as well. So enhancing staff engagement and boost staff performance with some of our clients over here in Australia. Really what we're saying is if you have things that you're really focused on that you want your nurses and your carers to do more of, assign some points to them. We'll calculate and incentivize people to do those things more. And then staff members who consistently meet those requirements will be given some rewards. and you have performance monitoring around that. For example, we have a client who is really worried about their weekend staff documenting things properly. So they're launching a gamification process to say all of their weekend staff, who's doing the best documentation schedules, and you may earn rewards such as additional annual leave or vouchers, and they're seeing their compliance on documentation go through the roof. And not just seeing their compliance go through the roof, their clinicians and staff members are actually happy to do the work because they can get rewards around that. And for us, that's a really, really key part of ensuring that the documentation is done properly and people are using the system properly. So overall, really, I'd kind of like to leave you with one thing is that, there's a lot of technology out there, a lot of different people that say they can do different things. One thing that we really do think sets us apart is that we do have a really, really strong kind of research and evidence-based background. We've built a system, but then we worked with the University of Canberra to do a 2-year independent study of how our system actually works qualitatively and quantitatively, the results of which are published in multiple journals and Deloitte have done studies around as well. I'd love for you to be able to download the case study that talks about it. But as I mentioned, we have a very, very strong evidence base, and we do return 20% of nurses' time away from doing administrative work to be able to do actual nursing work as well, which is really exciting. But I want to leave you kind of with one thing in the journal article that came out, which is that our Humanetix system allows the carers to see the person first. This was a quote that came from the daughter of a resident in one of the homes that we're in. And she told the researchers that actually for the first time, their father felt like the nurses were coming in and talking to him as a person because they weren't in a rush. They didn't have to come in and straight away do a whole bunch of tasks and activities. Everything was scheduled for them. They didn't have to worry about it. They could actually just look at the person as well and not see their father as a bunch of tasks and lists and stuff to be done. And for us, we know that is the most important part of healthcare, and we're very proud of the contributions that we move towards that, and really enabling carers to see the person as opposed to the problems the health problems that they have is the reason why we exist. So thank you very much. Really appreciate your time today. If you have any questions, please feel free to either ask it now or email me directly. I'm really appreciative for the opportunity to speak today and for you all that have taken time to kind of listen to me. Thank you.
Thank you, Arthur. Welcome. And we are going to have a look at the questions from our online audience. The first question would be, given that there are lots of care management platforms in the market, could you share more on the uniqueness and strengths of Humanetix? Hello, Arthur.
Hello, hi. Thank you very much. And that's actually a great question. It's one that our investors and our customers ask a lot. And I'll be really honest, at Humanetix, we don't spend too much time worrying about what other partners and what other platforms do, but we really focus on what our customers are asking for. I think we bring a very unique view of really focusing on how the nurses work, how to make their life simpler, as evidenced by our focus on the gamification piece that I spoke about, because we really do believe that the way to simplify care is to simplify a nurse's life. And if you simplify a nurse's life, then they will deliver better care. So the way we do is we pride ourselves on two things: being incredibly close to the nurses within the nursing homes, and actually aligning our platform and incentives within the platform to what the customer needs in that sense from there. And lastly, and we do it very, very quickly.
Thank you. The other question from our audience, what future features are planned for the platform that could enhance its effectiveness in long-term care management?
Yeah, great question. So we have a large pipeline of new features that are coming, but the ones that we're really focused on is combining all the different sensors and technologies within a a nursing home to combine into the single workflow. We know that there's a lot of innovation happening, but they usually require different systems. We want to bring all of that into the same workflow. So we're starting with fall detection sensors, which is a big problem, especially in Australia. We're then moving into motion sensors, trackings around that, and then underpinning that with a bunch of generative AI technology that we're bringing in to make decisions quicker and faster as well. That's on the one side. But the other side is that we're going to heavily invest in the gamification side of the nurses. Because as I mentioned before, we really want to make two things. We want the nurses to want and love to use the system more and more, and gamification is a key part of that. And then we want to be able to align the way the organizations need their nurses to operate by offering the rewards for them to do what they need to do.
That's amazing. It creates lots of incentive for the nurses so that they can keep doing their job well and also keeping them in the workforce. That is the most important thing.
Actually, you're right. That is the most important thing.
Yes. Another question from our audience. It's nice to know there is feature of generative AI for handover notes. Is it created because of high turnover of healthcare staff? And can you explain a bit further on this function and its benefits?
Yeah, it's a great question. And actually, this is a good example of how it's the nurses that we work with that tell us what their pain points are, and then we respond to that. So for us, it was really created because it wasn't not necessarily because of high turnover, but it was just making all the nurses really miserable. Everyone hates handover. In fact, I know I hate handover when I go on holiday and I have to get our COO to do everything like that. That's really where we came from. And that's why we started doing this experimentation around using the generative AI. We're very, very focused on the fact that for clinical decisions, generative AI still requires a bit of research, requires a little bit of work. But for things such as summarizing notes, it's a perfect use case around it. So what we do is really we take we sit down with each of the homes that we work with and kind of go, what are the key things that you need during your handover? And we actually generate the reports automatically through that. So each one's a little bit unique. Everyone has a little bit of a different shift structure. Everyone has different kind of nurses that come on board around that. And we kind of actually tailor that report to the customer around it.
I see. A question from the floor about the technical area. Is Humanetix could be as accessible on both cloud-based platforms and app? And if IoT device could be linked to your platform for different data collections?
Yes. So the answer is yes to all of that. So we are an app on the phone, but we also have learned that a lot of nurses still like to go back to their desk and type things in. So we really do meet the nurses where they are. So we are both a web app and a phone app as well. And as I mentioned before, we already integrate with a lot of different sensors, and that's kind of the two key areas for us to invest in and continue to add more sensors to the platform. So for example, we see a lot of cardiovascular sensors, things around using cardiovascular risk score being calculated in real time based on blood pressure sensors that we're adding into the system as well. So yes.
I see. Another question, what key challenges were encountered when implementing this platform across different care settings, and how to offer solutions?
Yeah, so what we've really learned is that every organization has kind of different challenges, but the broad ones are always typically the same. It's the change management side of how do you get the nurses to want to use their new system? Because it's very easy for them to say to them, and we actually believe this as well, a system is a system is a system. It's only as good as how much the nurses use them, which is why we drive a really strong incentive-driven way of doing it. Before we were doing the gamification stuff, before the original idea came from the fact that we were offering a lot of incentives for people to start using the system. And as they start to use the system, they see the benefits. And as the more benefits come through, they then start using it around. It really is about really understanding the change management side of the nurses. And ultimately, I think that's why the gamification piece will be so large as well, because people will be excited about using a gamification platform where they can earn extra days off or do different things.
I see. Another question also from our audience, how receptive were clients to sharing their sensitive health data, particularly concerning cybersecurity?
Yeah, great question. Great question. So we're lucky in the sense that Australia has really strong privacy laws around that and really strong kind of governance. You either are following the governance or you're not. So for us, we're following it. We have all the right protections around that. In that sense, we also are ISO 27001 certified. So we have an external auditor that checks all of that for us. And also our system can be deployed on a customer's premise or hosted in the country that they're in. So make sure that they own the data end to end around it.
I see. Thank you very much for your sharing and for introducing us to the innovative platform that make aged care management more comprehensive and accessible and more human to the people who work inside it.
Yes, no, thank you very much for everyone's time. And as I mentioned before, my email is there. Please feel free to email me or add me on LinkedIn or anything else like that.
Thank you very much. Thank you, Alpha.
Thank you.
So hello, everybody. My name is Amaia Calderón-Larrañaga. I am Associate Professor at the Aging Research Center of Karolinska Institutet. And the title of my talk today is The Health Assessment Tool, Monitoring Older Adults' Health for Preventive and Early Interventions. So this is the outline of my presentation today. I will start with a background, and I will refer in this case to the WHO Global Strategy on Aging and Health. I will then proceed to speak about the HAT, the Health Assessment Tool, and I will finish my talk speaking about the external validation of the HAT on one side and the validation of the HAT in the Swedish primary care on the other side. So let's start with the background. And these are the three components of the healthy aging definition of the WHO. Healthy aging was defined already in 2015 as the process of developing and maintaining the functional ability that enables well-being in older age. And as I said, there were three components to it. First, we have the intrinsic capacity, which is illustrated in this picture as the roots of a tree. And the intrinsic capacity comprises all the physical and mental capacities that a person can draw on. And it covers aspects such as mobility, sensory capacity, vitality, cognition, or psychological capacity. Now, surrounding those roots, we have the environment or the soil in which those roots grow. And the environment will actually shape what older people with a given level of intrinsic capacity can actually be and do. And this environment can or refers to both the social and physical environment. As an interaction between those roots, between the intrinsic capacity and the soil or the environment that, as I say, surrounds these roots, these both components will shape the magnitude, the quality, and the shape of the tree, the external part, what we call the functional ability. And the functional ability covers aspects related to the ability to meet older people's basic needs, but also the ability to learn, to grow, to make decisions, to be mobile, to build and maintain relationships, and to contribute to society. Now, even if this model lacks widespread empirical validation, it is a very interesting model because it includes important determinants of older people's well-being. And moreover, it is simple enough for its clinical use and even its incorporation into large population surveys. The core idea of this healthy aging model is that well-being should be conceptualized in terms of older people's capabilities. And these two components, the intrinsic capacity and functional ability, are key. While the intrinsic capacity will be the target for medical assessment and treatment, the functional ability is actually a reflection of its success. Moreover, this model recognizes both internal as well as external components to the individual body. In this sense, it puts a highlight on the social determinants of health, which is also very interesting and showing a clear added value. So based on these reflections and based on this background, we decided to develop the health assessment tool, which in our opinion, in our view, is actually a measure of intrinsic capacity. So we developed this health assessment tool with data from the Swedish National Study on Aging and Care in Kungsholmen. This is a cohort, an aging cohort study that follows people in the Kungsholmen town of Stockholm. And these people are over the age of 60 years, and they are followed every 3 or 6 years, depending on their age. And in each of these visits, people come to our center and they are extensively assessed for their physical, mental, and social health. So precisely thanks to these data that these participants of the SNAC-K have provided us, already in 2015, we could show that different indicators of health or poor health in old age tell us a different part of the whole story, and that all of them need to be used if we want to have a good understanding of health in old age. So if you see here, this is a graph where the x-axis shows us chronological age, and the y-axis is showing us the adjusted or sex-adjusted prevalence of each of these indicators. So if we start with chronic diseases or multimorbidity, having 2 or more chronic diseases, we see that this indicator of poor health becomes a bit more prevalent between the 60s and the 70s, but then there is a kind of plateau effect where we see that, it is no longer so discriminative. However, if we move to an indicator of mobility, in this case, slow walking speed, a walking speed below 1.2 meters per second, we see that this starts being very prevalent and increasingly prevalent after the age of 70. And it follows a kind of proportional increase over time. Now, if we look at a measure of global cognition, in this case, based on the MMSE, the Mini Mental State Examination. In this case, we're showing the prevalence of having an MMSE score below 27. And what we see is that this indicator of poor health starts becoming relevant after the age of around 80. And last but not least, we also have measures of functional independence or dependence, which become or start being relevant after the age of almost 85. And here we're showing the prevalence of having 1 or more limitations in the basic activities of daily living. So basically, when we look at this picture overall, we see that, as I said before, different components of older people's health linked to diseases, but also physical and cognitive function are essential to, do a good job in describing this complex phenomenon, which is health in old age. So precisely based on these 5 indicators, we use some sophisticated statistical techniques called the nominal response models to integrate all of this information together and come up with a single score, which is precisely the health assessment tool score, the HAT score. And this score takes values between 0 and 10. Higher values mean a better health. And it's very interesting because even if we integrate all of this information from these 5 health indicators into one score, when we look at the meaning of each of this unit increase in this score, we see that it follows a very intuitive and clinically meaningful significance. So for example, HAT scores between 0 and 2 indicate a severe functional dependence. You see here that people in this orange zone or line are actually affected by limitations in ADL as well as IADL. They have, of course, a low gait speed, a low MMSE score, and quite many chronic conditions simultaneously. Now, HAT scores between 3 and 5 would indicate a mild functional dependence, and now I'm referring to this light yellow line. If we go up to HAT scores between 5 and 8, then we see that subjects within this threshold would actually show a compromised physical and cognitive function with multimorbidity. If we go up to the green line, there we see that HAT scores between 8 and 9 indicate a slightly decreased physical and cognitive function with some morbidities. And then finally, HAT scores between 9 and 10 would indicate a good physical function and morbidity status. So as I say, it's an integrated measure of overall health in old age, but that has a big meaning and a clear hierarchy when we see the unit increases across the range of 0 to 10. And what is also worth mentioning is that a HAT score of 5 indicates a clear separation between individuals who are functionally dependent from those who are not. Now, the next thing that we did was to check the validity, the internal validity of the HAT, of the health assessment tool, within SNAC-K data. And for that, we checked different outcomes and the predictive capacity of the HAT against different outcomes linked to the formal care use, institutionalization, 2 different geriatric syndromes such as dementia and injurious falls, cell-rated health, quality of life measured through the SF-12, mortality, and unplanned hospitalizations. Now, in the red dots, or through the red dots, we want to show you the predictive capacity of the HAT by means of the C statistic, HARL-C. And then we also want to show you how the predictive capacity of the HAT compares to the predictive capacity of each of its 5 individual components: walking speed, limitations in ADL, limitations in IADL, number of chronic diseases, and MMSE. So what you see is that the C statistics across these range of outcomes is, for example, 0.82 for formal care use, 0.93 for institutionalization, 0.87 for dementia, 0.76 for injurious falls, 0.75 for cell-rated health, around 0.70 for quality of life, 0.84 for mortality, and 0.71 for unplanned hospitalizations. And it's also worth mentioning that on top of having very high C statistics for all of these outcomes, all of these C statistics are significantly higher than those seen for the individual components of the HAT. Moreover, we have also thought and designed HAT-related geriatric health charts, and the objective would be to be able to compare a person's HAT score against that of a reference population of the same age and sex. So for example, imagine we have a patient who has 0 ADL limitations, 0 IADL limitations, 0.9 meters per second gait speed, 2 chronic diseases, and an MMSE score of 29. And that, according to our calculation, is equal to a HAT score of 7. If that patient is a man who is 80 years old, that would mean, and if we follow here the blue dot on top of the graph, that would mean that this person is actually on the 70th percentile. And that means that 70% of men of that age, of 80 years, are actually doing better, while 30% are doing worse. Now, if that person with a HAT score of 7 would be 87 years old instead of 80, that would mean that this person would be actually falling in the median. And what does that mean? Well, that means that 50% of men of 87 years are actually doing better, while 50% are doing worse. So the idea behind these HAT-related geriatric health charts is exactly the same as the one used for children in terms of, or when we monitor their height and weight during the first years of their lives, precisely to see how these older people are doing compared to a reference population of their same age, but also longitudinally. If this person who is 80 years old today has a HAT score of 7, and what would his or HAT score be in 6 months, for example? And would this future HAT score be aligned with the expected curve, or would it be below, indicating an accelerated health decline, a health decline that goes beyond expected? So now I'm moving on to the third point, and I want to speak briefly about the external validation of the HAT. And for that, we used the SNAC national study. Let me briefly tell you that the same protocols of data collection that are used in the SNAC K study, Snack-Kungsholmen study, the second box here, are also used in another 3 sites. In the north of Sweden, in Nordanstig, in Blekinge in the south, and in Skåne, further to the south of Sweden. And what is interesting here is that on top of collecting the data using the same protocols, these 4 sites cover a range of rural, urban, and semi-rural areas of Sweden. So using these data, we wanted to actually externally validate this HAT tool. And we did this by looking at different outcomes in each of the sites separately or in a stratified way, and then meta-analyzing these predictive estimates that we had obtained for each site separately. So let me take you slowly through this graph. What we see here is that the C statistic, the Harrell C, for time to death throughout a 15-year follow-up, if we meta-analyze the 4 estimates that we get for the 4 sites, the C statistic is actually 0.76. Now, the area under the curve, the AUC estimate for 1-year mortality was 0.86 when we meta-analyzed those estimates obtained for each site. The AUC estimate for 3-year mortality was 0.83. The meta-analyzed AUC estimate for 5-year mortality was 0.82. The meta-analyzed AUC estimate for 1-year unplanned admission was 0.70. And for 3-year unplanned admission, it was 0.69. Now, it's difficult to compare this with other measures existing in the literature because few studies have actually looked at different indices of health in old age in one same study. But there is actually one publication from 2021 where they compared 7 frailty instruments in one same cohort study of community dwelling older adults. And what they found there is that the highest AUC estimate was found for 1-year hospitalization. And this estimate was for the frailty index, and the number was 0.62. So, you know, if we go back to our results, we got AUC estimate of 0.70 for 1-year unplanned admission. So, you know, we can see that this tool is doing quite better than even the best frailty assessment tools that we have available these days. We even designed these HAT score related geriatric charts for each of the 4 sites, as well as for the total SNAC population. And it's, you know, from this perspective, we see that it's a very interesting tool also from a public health perspective because it enables us to compare the distribution of those HAT percentiles across sites, geographical sites, for example. Now, moving to the last part of my presentation, I'm going to speak very briefly about the validation of the HAT in the Swedish primary care. And why primary care? Well, primary care staff have the best competence to monitor, preserve, and improve older people's intrinsic capacity. And it's not us who say it, but it's the WHO Global Strategy on Aging and Health, who stated already in 2022 that a key goal was to promote healthy aging by optimizing health trajectories from primary care. And this is why we thought that HAT could be a very interesting tool to monitor these health trajectories precisely in primary care. So we collected data for these 5 indicators that conform the HAT throughout 2023 and 2024. We just finished the data collection coming from 6 urban, rural, and semi-rural primary care centers across Sweden. We have data for 1,000 patients, and we are precisely going to start the analysis to check the external validity of the tool in primary care now, these days. So it's going to be very exciting, and we hope to be able to keep you posted. But what I want to say is that apart from collecting these quantitative data, we also wanted to check with our primary care physicians and primary care professionals what was, in their view, the acceptability and usability of this tool in routine primary care practice. And this is what we saw. Well, indeed, primary care professionals, but also patients themselves, do see that HAT could have an added value in terms of identifying quick health changes over time, but also as a visual aid to promote health awareness. And this is a patient himself who was stating this. HAT could be used as a screening tool, not only in general for health, but also for dementia, for example. It is an interesting way to systematically assess health in old age. And it's also interesting as a tool that could help break taboos. There was one of the healthcare professionals saying that they realized that patients appreciate it when they are asked about different kind of impairments, for example, incontinence, which might not always come naturally and spontaneously in a consultation. So, in summary, there are many advantages of the HAT. It seems to be an optimal predictor for several outcomes across a range of healthcare use, geriatric syndromes, quality of life, and social care use. It mitigates the ceiling or floor effects of some of its individual components, and moreover, it assembles several health indicators into one single score, reducing the need to interpret multiple criteria. And the potential of applying HAT beyond research is very, very high, as we saw from our interviews to the primary care professionals. It could help definitely to monitor this intrinsic capacity from primary care, and it could actually also be an interesting tool to prompt and promote discussions between the GPs and patients working in patients and GPs working in primary care regarding their preferences in late life based on biological instead of chronological age. And moreover, from a public health perspective, it is an interesting risk stratification tool. So with this, I would like to thank you all for listening to this talk. And I would, of course, like to thank also the SNAC-K participants, the SNAC-K data collection staff, the National Infrastructure for Aging Research, which helped us with the harmonization of the 4 SNAC sites to do this external validation of the HAT, as well as the funders of our research. Thank you.